Thank you so much for joining. Unfortunately, Dr. Shu cannot attend because his father died immediately before. Because we decided to give it some lectures and change it. My topic is the evolution of the endoscopic spine surgery because I think that maybe it will be the future of the spine treatment and spine surgery. This is my curriculum writing disclosure. During last 20 years, the endoscopic spine surgery started maybe 20 or 30 years ago, but the evolution maybe started maybe 10 years ago, and two way. One way is the evolution of the surgical techniques of the endoscopic treatment, like this Shupra technique, and so many techniques. And another way is the some development of the instrument. This instrument scope also improved so much, and some adjunctive equipment also developed so much because of that. Nowadays, we can apply this so many indication of degenerative spine using the endoscope. Nowadays, we saw near all levels of degenerative is treated under the endoscope currently. For example, we saw that like these cases, so severe highly inferior migrate cases and so severe canal compromised cases, bilateral L5S and rupture these cases and stenosis cases. These cases is the only immediate before is the contraindication of the endoscopic spine surgery, but after evolution of the endoscopic spine surgery, like this, all cases treated under the endoscopically, and the patient take a more good result compared to the before time. Firstly, we discussing the endoscopic transfemoral dissection because the endoscopic surgery started from the transfemoral approach by and firstly, Dr. Cambin naming this transfemoral area Cambin triangle. We already know that this Cambin triangle, but firstly, endoscope process only approach from this intervertebral space of in and out technique. Some doctors using out-end technique, but that time there has two indicate barriers. Of one barrier is the anatomical barrier, especially highly inferior migratory cases. But and on another barrier is the neurological barrier, especially related to the dorsal ganglion. But anyway, like this. Anatomical barrier of the highly inferior migratory cases and neurological barrier of the extensor disc can be treated nowadays under the endoscope currently. And also there have some several limitations of these barriers. Before time we already well known that this migration and canal compromise and iliac crest and hard bony foraminal width. But we remind that these two limitations is related to the one is the axial plane limitation and one another is the sagittal plane limitation. Before time, this also not easy to overcome under the endoscope, but now some developing the instrument and techniques, this anatomical barrier can overcome under the endoscope, and but we should approach this transfemoral approach route safely without some another organ damage. We choose the safety area using this landmark. And we now remind the surgical approach of the transfemoral approach. We can see here the external the traversing route. We approach it from this skin to this Cambin triangle. But firstly, we talking the outer big Cambin triangle, but we hope to approach more close to the target point because of that. If you insert firstly big Cambin triangle, but after then you insert more deeply some more small triangle. And always we checking the damage of the nerve using the several techniques. And if you met some complications, difficulties, you can overcome the problems using like this drill or limbing techniques. And also we can approach from this transforaminal root area by the three different approach route. This intervertebral route and foraminal route and suprapedicular route. In this approach, you can see that in epidural approach, mainly using the intervertebral route, most important point will be the making half and half, because that is more easy to approach to the epidural space. In the foraminal, using existing route approach, using the foraminal route, most important point will be the protecting the dorsal root ganglion. And first and second will be the approach to the more deepest point for remain the disc. And the traversing route approach of the suprapedicular roots will be the most important, will be exposure the target point, because they have some anatomical barrier. And using several techniques, nowadays we can approach to this target point. I show some of the cases. Actually, this is a foraminal to supromigration cases of neurological limitations, but nowadays it can possible to overcome this problem using the endoscope. And we already talking that in these neurological limitations, the most important point will be the dorsal root ganglion protection. And another things, should checking the multi-filament in foraminal to supromigration extremity cases. And finally, it should checking the free axillary area. That is the most important point in the exiting route approach. And in the cases of phalangeal disc cases, also neurological limitation, these cases, sometimes the patient complains severe pain during the procedure. But if you're using the floating technique, this problem also can overcome more easily. And also, we already mentioned that this high canal compromise case, most important point will be exposure the epidural space using the half and half technique. And also some nowadays so many anatomical barriers like this highly inferior migration cases will overcome using the endoscopic drill to open to here. And also the lesion cases after open microdiscectomy seems like difficult, but fortunately this area is a virgin area, because transforaminal endoscopic discectomy can possible more safely. And like this, some partial calcified these cases also can possible using the calcification floating technique. Sorry. And one another limitations, this actually we know that the foraminal stenosis can possible transforaminal, but we should know that this foraminal stenosis is related to the neurological limitation and anatomical limitations, because we should overcome these two problems in the foraminal decompression. Anyway, we hope to try all degenerative diseases under the endoscopic, but unfortunately, L5 and S1 has some anatomical barrier of the high iliac crest and narrow foraminal width. But that also, fortunately, there has some more wide intraminal space. Because of that, many doctors try the intraminal approach. But I recommend if you apply the intraminal approach, if it possible, apply the structural preservation technique. The structural preservation technique using the ligament flavum splitting and annular sealing. And firstly, docking the obturator to the deepest point of the annulus, the ligament flavum. After then, you can expose this ligament flavum more safely. And this structural preservation technique is made by the ligament flavum splitting and annular sealing procedures. This process is showing the structural preservation L5S1 intraminal discectomy procedures. Firstly, splitting the ligament flavum After then, explore the axilla, sometimes the shoulder, and then move to the target point. And if it's possible, only some making whole a small point only, and remove the rupture disc through that hole. After then, remove the rupture disc. We try the sealing of this area. They can decrease the post-operative recurrence after rheumatectomy. Can see the some of cases in terms of cases. You can see the after operation. This MRI taken 4 hours later. You can see the ligament flavum and annular seal they are completely. But some doctors maybe some talking that what is different of the open surgery, but actually this preservation of the these old structures can save the neural stream there completely. It means that decreasing the adhesion and decreasing the some preserve the neural stream more sufficiently. This in the cases highly inferior migration cases, you can target to the caudal point, and you can limit this rupture disc more sufficiently. And in the cases of highly superior migration cases of F5S, you can target to this point and split to here and limit the rupture disc only. And also, Dr. Nitin already commented this in the L5S on foraminal to superior migration is most difficult because the transforaminal also difficult, intraminal, ipsilateral intraminal also difficult because in that at that time, if you operate from the contralateral side, you can limit this pathology more sufficiently without damage of the neural structures. And also, like this process, structural preservation technique can possible lesion surgery of the after open microdiscectomy using firstly checking the bony structures, after then splitting this point using some probable radio frequency. After then, you can limit this rupture disc without damage of another structures. And I will show that this bilateral cases. This case seems like maybe not possible endoscopically, but if you try the endoscope internal, it maybe need a bilateral, but nowadays it can possible to the ventral dural approach from this side to contralateral side. It can possible. Dr. Ju now processing the paperwork. So then nowadays the endoscopic decompression is developed, starting and developed some of doctors, and I believe that this will be the future of the endoscopic spine surgery. But yesterday I talking that this pathology of the spinal stenosis is not same with the rheumatic condition because this stenosis mainly related to the instability. Because of that, if we met the stenosis cases under the endoscope, we should remove the pathology point of the ligament flavum and the osteophytic point, but we should preserve the normal structures. There is a course of the endoscopic rheumatic compression. Dr. Nitin talking that this anatomical variation of the foraminal stenosis related to the maybe stenosis related maybe happen by the ligament flavum, osteophytic point, and disc, and around the bony structures. And this technique already published in the paper, and this another technique that recommended by Professor Joe. And anyway, the development of the endoscopic drill nowadays near all area can operate under the endoscopically in spite of the deepest point of the contralateral side can possible. You can see the contralateral lateral recess after then exposure the contralateral foramen. I pass because I have no sufficient time. And sometimes the bipolar surgery can possible more easily, but in unipolar sometimes more difficult using the big scope channel. Most deepest point is not easy to approach at the time. We can approach the deepest point using the small channel, using the channel technique. And then we can see that here point is the contralateral extraforaminal area of the ore acting to decompress sufficiently. This image already shown Professor Chu, RPS. And then nowadays we can possible, ipsilateral can possible and contralateral can possible. But unfortunately, ipsilateral foramen is not possible because of the if the patient have some bilateral foraminal stenosis cases, but maybe that time need some another surgical procedures. But anyway, the main goals of the endoscopic decompression will not only cosmetic effect and early recovery. More important point will be the minimizing the facet joint violation and the real target-oriented surgery. That is a more important point of this endoscopic spine surgery, because we believe that the endoscopic decompression is similar to the open micro lumbar decompression, but I think that's some different, because we can approach more deepest point without damage of the another structure more sufficiently, more seriously. I will show some of the cases. Like these cases, we only hope to remove this point because the patient complains severe pain after rupture of the calcified ligament. But if we do, because this level is L23, if we doing the open surgery, it maybe need some violation of this point. But if we approach from the contralateral side of the endoscopic, we can preserve the all facet joints and all structures completely. That is real target oriented. And also nowadays this central stenosis is a common process in Korea, and main point will be the preserve the facet and preserve the paraspinal muscle. You can see here the both facet joints preserved completely and paraspinal muscle preserved completely. And also in the cases, more severe cases, it can possible endoscopically. But I think that maybe if we met the instability or more serious cases of stenosis, maybe some have a chance of the neural damage. In the cases, first we choose the micro open discectomy rather than the endoscopic discectomy. That is more safe for the patient. And anyway, using this endoscopic procedures, we can checking the deepest point of the contralateral side and ipsilateral side. And you can see here that this lateral stenosis, central stenosis, and foraminal stenosis. In that cases, before time, we need some fusion surgery. But nowadays, it can possible only endoscopically without fusion surgery. It means that minimizing the chance of the fusion surgery. And also nowadays in Korea, many doctors doing the posterior foraminotomy surgery by the endoscopically. We can see the many cases of this preoperative showing the rupture disc and postoperative showing the removal of the rupture disc. And another case is also showing the wear decompression and foraminal pathology. I think that maybe nowadays the endoscopic spine surgery developed so much after the starting using the endoscope drill and the development of the equipment. Because of that, naming the new land after percutaneous endoscopic spine surgery. Today, I talking so many times. We propose the percutaneous endoscopic spine surgery real target oriented for decompress another structure saved if possible sufficiently. We can see this case before time, but if we This patient only complained the left side. We hope to limit this only point. And it can possible under the endoscopically. That can preserve this patient, returning this patient in spite of the very old age. And also this case showing the similar, this 74-year-old osteoporotic and already received the vertebral thrust, and general condition is not good, but the patient complained the severe leg pain. But if we doing these procedures, not general decompression sufficiently, the patient can return their life more sufficiently. Is there any limitation of surgery for degenerative spine surgery? Yes, still have some limitation, but after developing the endoscopic spine surgery, I think they may be near all degenerative spinal can treated under the endoscopically. For first time we show in these cases, but the last time this is contraindication, but this time is can possible using the scope and techniques, surgical techniques, and the patient can take a good result. And also this case showing the Barrett-Rutte syndrome, and also nowadays some doctors try the Fowler syndrome using the endoscopically. Also after then, nowadays we can apply the endoscopically for decompress this point. And this case, but anyway, if we preserve the oral structures, firstly, believe that the transforaminal is more good option. But in some of cases like this, severe canal stenosis and highly inferior migration cases is not possible in transforaminal. But if we hope to decompression to here and limb to here, in the cases decompress the decentral stenosis, and then using the channel technique and then limb the rupture disc, the patient can take then good result using these procedures. But I believe that nowadays the management of degenerative spinal surgery may be shifted from the open surgery to percutaneous endoscopic spine procedures. For example, these cases receive the open micro decompression and dissecting, but the patient complains severe back pain, leg pain more than 6 months. But you can hear some loss of spinal alignment and some collapse. But this pathology here, because of that, maybe if we met this patient before time, he maybe need a 1 or 2 level fusion surgery. But if we doing the endoscopic spinal discectomy and give the well restoration of the spinal alignment with the rehabilitation, the patient will restore their alignment, and the patient will take their life completely. And also, before time we saw this case is 90-year male patient, only NIC 5 meter. Before time, this is not possible treat for this patient, but nowadays it can possible using the endoscopically and decompress all 3 levels, these 2 skination, and the patient work immediately after operation. Yesterday, I took in this point, 2 points. Maybe some doctors in 3 level try the 1 skination, but I think that maybe if bilateral multi-level decompression will give more chance of the segmental violation. Because of that, if we in my cases, I met 3 level cases. I recommend the 2 level different skination for saving the segmental instability. And also nowadays this case is 63-year female patient with coda echina and foot drop patient. If we perform open surgery, it also has some chance of the remain coda echina and foot drop because we should retract the already damaged nerve. But if we approach it from the transforaminal area, we can remove this pathology without retraction and without damage of the nerve. This video may be taken 2 weeks later after operation, but I followed this 3 months. Now the motor recovered completely now. And this is the final case. Actually, this patient came to my clinic. Sorry, this image is some rotated, but this patient came to my clinic with a foot near bilateral foot drop state, and you can see the L23 severe stenosis and L45 ruptured inferior migration, L5S1 central stenosis, and L5S1 bilateral disc. Wow, that's crazy things. But this patient received endoscopic spine surgery. Maybe time needed 3 hours 30 minutes. And first we decompress the L23 level, and this all video. Firstly, we decompress L23 level. Post-operative image showing the well decompression. After then, decompress the L5S1. You can see the ipsilateral exiting traversing the root here and decompress to here. Compress well. And then I remove the L45 highly inferior migration disc from the L5S1 contralateral side. From here, you can using the small channel, using the channel approach from the left side to right L5, and then remove this disc. And then after then, L45 transfemoral, L5S1 extrafemoral during the one skin scan, and you can see the postoperative images of skin. And the patient immediately next day, the patient motor recovered near half, and I followed this patient 1 month. Nowadays, the patient right side greater. Grade 3 only remained. Another all things recovered completely. You can see the post-operative images here, well decompressed near all level. And these final cases of the intradural ruptured cases. Maybe this patient also came with a very severe pain. But if we're doing the post-operative, maybe need a dural incision and the transdural approaching, maybe some remaining the some neural damage. But if we doing the transfemoral, you can see here that some ruptured points, dural tear points, and then if we cancel the this teared point, the patient disc can remove without damage of the nerve, because we approach from the ventral side of the first original tear point. This rupture disc of the intradural area, you can see here the tear point, and the rim, the rupture disc here, intradural rupture disc here. And then you can check the free. So after then, seal to here using the taco comb and gel foam. I will show. Firstly, insert gel foam to intradural, because the most serious complication of the dural tear of the ventral parts happened by the prolapse of the rootlet, because the prevention of the rootlet prolapse is most important point. After then, seal this point using the taco comb. After then, the patient can walk. This video taken 1 week later after procedures. The patient have no pain, have no problems after walking. Satisfied completely. Yes, the result is near similar to the Dr. Nitin because it made by me. Yes, before time, the endoscopic spine surgery believed that the only minimized option, but it means that the minimized treatment. But nowadays we doing the real target-oriented surgery because of the endoscopic spine surgery is nowadays not minimized surgery. There is a we can take a maximized result with using the minimized option. Thank you for your kind attention, and